What's going on, everyone? Welcome back to another episode of the Muscle Memoirs Podcast. Today, it is my pleasure to be joined by Dr. Nicola Guess. Dr. Guess, how you doing today?
I'm really good, thanks. How are you?
I'm doing fantastic. I'm really excited for our discussion today. I think we're really going to get into the weeds of a fascinating topic. You've been dropping some heat on Twitter recently. It's been a pleasure to view that from the outside looking in. The low carb diet or the ketogenic diet, it's a pretty polarizing strategy within a nutrition community. Some people think carbohydrates are inherently fattening. The only way to eat is a low carb diet. For others, they more or less put forth that you'll die if you follow a ketogenic approach for longer than a few months. But as this dietary strategy has increased in popularity, we're starting to get more and more research on it. And specifically, most recently, we have started to get some nice review papers on the topic, looking at ketogenic and low carb diets for weight loss. And for the purpose of this discussion, these sorts of diets for diabetes. And we have two recent meta-analyses looking at this, and from my understanding, looking through these papers, they kind of suffer from the same flaws, so to speak, and they kind of point in the same direction in terms of results. And on Twitter, you put together a absolutely fantastic thread going over the most recent of these, which was published in the BMJ. So for our listeners, can you provide some of the details of these reviews, basically our current understanding of these dietary approaches for preventing and managing diabetes? What are the flaws in terms of the reviews on this topic, and what can we really take away from these?
Sure. So the flaws really start with the studies themselves. So as you've said, there are meta-analyses that compare lots of different trials. And the problem is that all the trials do something different. So none of them even compare the same amount of carbohydrate. So some of them, for example, call low carb 120 grams of carb a day. And there's this kind of assumption, okay, everyone's on 200 grams of carb a day plus on a normal diet. Surely if we reduce it by 100 grams, you're obviously going to get a reduction in glycemia. Now, we don't know that. There's no physiological data out there that even supports that we have. Now, it doesn't really support the opposite. So we don't know either way. We don't know if it lowers glucose. We don't know whether it increases glucose. So we need better controlled studies that are comparing like for like in terms of carbohydrate. That's the first thing. The second thing, and a huge interest of mine, is protein. So the amino acids within protein are insulinogenic. So they make the pancreas produce a lot of insulin. If you give protein with carbohydrate, you can triple the amount of insulin that's produced. And guess what that does? It lowers blood glucose. And these meta-analyses don't account for that. Even within the trials themselves, very few even control for it. So for example, you might see a low carb, quote unquote, low carb study that's actually 30% of calories from protein. But they compare it to a high carb study that's 15% of calories from protein. And that design cannot tell you whether it's the carbohydrate or the protein or both, which are influencing glycemia. The third thing is medications. Many of the studies don't even account for medications. And there's a paper that was published many, many years ago by Davey et al. It was done in the UK, and it compared low to high carb, very short term. And they didn't even intend in the beginning to measure change in medications. So their primary outcome was a reduction in insulin, etc. A reduction in glucose, etc. And they didn't see huge differences. But in their discussion, they note that once they'd finished the study and written everything up, one of the nurses kind of came to them and said, wow, that low carb group is great, isn't it? The diet's brilliant, because they all came off their medications. So the investigators say, well, we went back to the data and looked at who came off the most medications, and actually it was something like 90% of the low carb group came off meds compared to something like 10% in the control group. So you think that is insane that we don't control for that. And the final thing is weight. different people lose different amounts of weight, and weight is a potent driver of glycemia. So my issue with meta-analyses and my whole thread was not about low carb diets being good or bad, not about a diet working better to get people off their medications. It's the fact that these meta-analyses are so flawed, they can't tell you anything.
Excellent. Now, you raised a point there, and I would say, following nutrition Twitter, seeing what many of the practitioners are talking about over there, they're kind of spurred this debate about the effect of restricting carbohydrates on glycemia. And I would say that most people, their understanding would be, well, you reduce carbs, you improve glycemia. You're not going to have these these peaks and valleys in your blood glucose throughout the day. The peak glucose following a meal, it's going to be lower if there's a lower amount of carbohydrates within that. And as you just put forth, it's a little more complicated than that. So could you maybe touch on some of these nuances for the listeners, and why it's not necessarily so cut and dry? You reduce carbohydrates, you improve overall glycemia, whether that be fasted, postprandial, or over 24 hours.
Yeah, that's a really great question. So absolutely, there is data, very good data, and it's been around for a long time, showing acutely reducing carbohydrate influences postprandial glycemia. And this is done on a single meal test where you give a meal differing in carbohydrate amounts to the same person in randomized order. That we know. The question, obviously, for the utility of a diet for a person over time is that hypoglycemic effect sustained? And that's the interesting thing for me. And actually, it's astounding that we really have never tested that properly. And the reason why it's very unlikely that simply the acute effect will be maintained long term is many adaptations that we know happens. So even in healthy people and people with type 2 diabetes, we have pretty good evidence that a large enough reduction in carbohydrate will, over a period of 2 to 11 days, the studies have been of varying length, reduce the amount of glycogen that's broken down. So the amount of glucose production is reduced. Now you do get a slight increase in gluconeogenesis. That's the glucose that is being made from either amino acids or glycerol. There's a tiny increase in gluconeogenesis, but that is far outweighed by a huge reduction in glycogenolysis. And that's the breakdown of glycogen. And that's one of the adaptations which will have the combined effect of reducing the amount of glucose the body makes itself. And it does that because it doesn't need to control glucose in the same way compared to a high carbohydrate diet. One of the other adaptations is a change in glucose uptake into the periphery. And that also alters. So just because you maybe intentionally reduce the amount of carbohydrate you're eating, your body can respond by reducing the amount of glucose it produces and reducing the amount of glucose that it either takes up or releases from the tissues.
So is our main point that we're looking at here in terms of 24-hour glycemia, whereas that specifically, it's not necessarily per se that reducing carbs would improve this metric? Or is it for all of them?
Oh, a great question. So you're referring to kind of 24-hour glucose postprandial fasting, for example?
Right.
Yeah. Based on the data we have that has looked at 24-hour glucose, and the vast majority of these also have really high protein, or they have super high monounsaturated fat, it looks like the majority of the effect is postprandial.
Okay.
And over time, maybe you do start to get a reduction in fasting glucose. And that might not be because of the reduction in carb, the increase in protein, whatever it might be. That's probably a secondary effect of the reduction in postprandial glycemia, improving fasting glucose homeostasis.
Excellent. Thank you for that clarification. If we move back here to these meta-analyses, which you mentioned, we can't necessarily make too much of these. It seems like the results, at the very least, point towards low-carb diets potentially being superior for some of these outcomes in the short term, around 6 months. Is that correct?
Yeah, most of the data tells us that is the case for weight and glycemia.
So this leads into our next question here, and that is, if it matters, if one diet is better than another over the long term, or to state otherwise, couldn't we just put someone with type 2 diabetes on a low carb diet for, say, 6 months, thinking that this could potentially improve outcomes, right? If we equate for adherence, and they're going to follow the diet regardless, and this could improve outcomes at 6 months, and then we can always just transition them to another diet that is more sustainable in the long term.
Are you asking what the effect would be on glycemia with that approach?
Right. So within this debate of, dietary approaches for diabetes, and a lot of people thinking, well, obviously, if you're diabetic, you shouldn't be consuming a high carbohydrate diet. And then if we look at these reviews suggesting that, well, maybe in the short term, there is a benefit or superiority to low carb, but definitely not over the long term. And then, we have this debate about which side is right and which side is wrong. And from my point of view, it's like, well, what if we took an approach in the middle and we just use low carb in the short term, considering it shows some superiority? Would we be able to just maintain those benefits and then transition to something else in the long term that's more sustainable? Perhaps to state otherwise would be, could the optimal approach per se just be utilizing both, depending on the situation of the person and at what point within the progression of the disease that they're in, if that makes sense.
Yeah, so there are many ways of answering that question. So the holy grail, of course, is remission, getting remission of
Yeah.
type 2. And the problem that we have is that the definition of remission is based upon glycemia. So it's not, the definition of remission isn't saying you need to get pancreatic function back to what it was. Or it's not saying you need to get liver insulin sensitivity back to what it was. It's about glycemia. And so I think low carbohydrates could achieve remission. By the way, low carb, high protein. I think for type 2 diabetes, that's the optimal combination. I think that could achieve remission of type 2 diabetes without necessarily a person losing much weight, and without them needing to get their insulin response and all of the normal pathophysiology up and running again. But for that to be the case, they would have to follow that diet over time. So that's a kind of different approach to, say, the direct trial. And if we take the direct trial, that was where you had a marked weight loss period of, say, 3 to 4 months. What that did is reboot the beta cells of the pancreas, improved hepatic and peripheral insulin sensitivity, and it was those changes that then got normal glycemia. And I guess we can kind of maybe differentiate and call that durable remission, in the sense that you're fixing all of the underlying stuff and the person can then go back on and consume the same diet. So that's where most of the thinking is now, but there are another couple of issues that are worth considering. A third is that we know from studies that have achieved normal glucose in people with type 2 diabetes. So there are studies, for example, that give people really high insulin doses, really intensive insulin treatment shortly after diagnosis, or even during the course of the condition for, say, 2 or 3 weeks. They get super high insulin to really lower blood glucose just for 2 to 3 weeks. And what that does, that achievement of normal glycemia, is that in itself helps restore the pancreas, so the beta cells of the pancreas. It's a concept we call beta cell rest. And what's striking about those insulin studies is that then if you remove the insulin treatment, people can have pretty much normal blood glucose level and diet controlled diabetes for up to a year, up to 2 years. So simply exposing a person with type 2 diabetes to a period of normal blood glucose for even 2 weeks is sufficient, we think, to restore the underlying pathophysiology of type 2. And so I think this is a question I'm speculating. If you could have a low carb diet that went low enough, or low carb, high protein, or any kind of diet that just achieved normal blood glucose, that in itself might fix stuff so they can then take another diet that's more sustainable for them long term. But this is all speculation and we don't know.
Yeah, that is fascinating, right? Because when we look at direct, as you mentioned, I believe a similar trial just came out. It was conducted in the Middle East. I don't know if you know what I'm referring to there. I forget the name
Yeah.
of it. You do?
Yeah, the one done in Qatar, basically tested direct, but in another population.
Yeah.
Yeah.
And when we look at this research that's compiling all of the great stuff that Roy Taylor has done, it does seem like the magnitude of weight loss is the most responsible for improving the management of type 2 diabetes or achieving the holy grail, right? But as you put forth that, theoretically, if we use some sort of low carbohydrate, high protein approach, maybe we could achieve these outcomes with less weight loss than we're seeing in these trials, which is really fascinating. On this podcast, one could say that maybe we're in the pockets of big protein. We're all about protein on this podcast.
Good.
Usually we're doing episodes with bodybuilders or sports nutrition professionals, and we like to promote the importance of protein for athletes, but also understanding that for the general population, people looking to improve their health, protein has a really important role. So for you in this discussion on type 2 diabetes, to mention the importance of protein, that's music to our ears. Could you elaborate on the benefits of a high protein, or consuming roughly 25 to 30% of daily energy intake from protein for type 2 diabetics? I think our listeners will most likely consider the benefits on satiety and how that might improve an individual's ability to adhere to the energy deficit more or less required to improve type 2 diabetes. And of course, all of these benefits for skeletal muscle mass and being able to preserve that in an energy deficit, and maybe even increase it in the best case scenario. But what are some other benefits of protein that most people don't consider?
Sure. Well, I think there are two which are so relevant for type 2 diabetes. The first is insulin secretion, which I can talk about. And the second is liver fat. And of course, fat deposition into the liver is so closely linked to insulin sensitivity. If you have a liver fat percentage above 5, your risk of developing type 2 diabetes increases 2 to 3-fold. So even within the context of having type 2 diabetes, if you have elevated liver fat, you're less likely to get remission. So one of the things that happen with direct, with any kind of weight loss, if you lose the amount of weight you lose in direct, liver fat reduces, but almost certainly that is linked to improvements in insulin sensitivity. So the good news with liver fat is it's exquisitely sensitive to weight loss. So anyone who loses weight or even does exercise can massively reduce their liver fat. But again, what's so powerful about protein is it can do it without weight loss. There's some very good studies, which each of them individually isn't like a gold standard study, but if you combine all of the data together, there is a consistent finding that added protein or individual amino acids can lower liver fat without people losing weight. And I think this is probably really important with remission too. In other words, let's say you achieve remission, however you do that. One of the things that seems to get people to relapse into type 2 diabetes is fat starts going back into the liver again. Now, if you can stop that from happening, potentially you can increase the duration that someone can remain in remission of type 2 diabetes. So the liver fat thing is something that people forget, but I think that's really important. But for me, the most exciting thing and so relevant to type 2 diabetes is insulin secretion, because that's really what controls blood glucose. That's what gets people remission. So going back to the direct trial, in the people that got remission and people that didn't, so everyone who lost weight lost liver fat, everyone who lost weight lost pancreatic fat, but the distinguishing factor between people who got remission and didn't was getting what we call first phase insulin response back. And that's the enormous peak of insulin that occurs in anyone who's healthy and doesn't have diabetes. And you're able to reboot in a way the beta cells to do that with weight loss. But what amino acids can probably do is get very, very close to that kind of maximal insulin secretory response without requiring people to lose weight. And one thing that is so exciting is that seems to be the case even in long-standing type 2 diabetes. And at the moment with remission, the general consensus is the longer you have type 2, the less chance you have of getting remission. And my view is we've kind of written those people off and kind of said, oh, well, poor you, you've had type 2 for 6 years, for 10 years. We can't prioritize you for remission programs because it's probably not going to be likely. Whereas I think there's real potential for high protein or maybe some individual amino acids to produce that massive insulin response to get remission in long-term type 2. But that we need to look at.
Is there a unique benefit on the secretion of incretin hormones as well, or is that just kind of a consequence of this increased insulin secretion?
We don't really know. I mean, actually, if you look at studies that compare macronutrient content or different macronutrient content of acute meals, there doesn't seem to be a huge difference in incretin or indeed the appetite hormones. So you've got GLP-1, which is an incretin, but it's also an appetite hormone. Then you've got kind of PYY and the other kind of gut-derived appetite signals. There doesn't seem to be a difference in either consistent between high protein or high fat. It seems to be that, I think, the amount of GLP-1 you produce is mostly driven by the energy content of the meal.
What's going on, everyone? I wanted to briefly interrupt this episode to tell you about the new Hammer Away newsletter. Each Sunday, you will receive an email containing a breakdown of a recent exercise science or nutrition study, as well as some practical takeaways. Also, I'll be linking other content that I think is worth checking out, such as social media posts, articles, and videos. As a dedicated listener of the Muscle Memoirs podcast, I know you love all things evidence-based fitness, and for this reason, you're going to love this newsletter, which will serve as a valuable resource for those interested in keeping up to date on the latest research and trends. To sign up, head over to hammerawayfitness.com or copy and paste the link in the show notes. Now back to the episode. Awesome. I think this brings us to the types of protein, which may be more positive or negative depending on what we're looking at. And traditionally speaking, if we're looking at generally healthy populations, people focus on the quality of protein in respect to the quantity of amino acids it provides and the profile. Is it providing all of the essential amino acids? But I think there are some other really important points to consider here, particularly how the other nutrients that come with these protein sources, right? So when we're looking at vegetable sources of protein and the phytochemicals they provide and the fiber and the potential benefits for insulin sensitivity from those. And of course, if we look at animal products, everyone likes to make a big deal out of red meat, right? And as we know, it's probably not as cut and dry as most people like to think. It seems these negative outcomes that people like to talk about are probably more so related to processed meats, talking about things like bacon and hot dogs rather than a lean steak. But could you outline for our listeners, when we're looking at, generally speaking, plants versus animal protein sources, perhaps which ones seem to be more beneficial on insulin sensitivity, and then maybe we can dive into specific foods from each category?
Yeah, I mean, so let's start with the two parts of type 2 diabetes. You've got the insulin secretion and the insulin sensitivity. So far as we know with the insulin secretion, it's driven by the amount of amino acids in the bloodstream rather than individual combinations. And really, there's just the reason for that is the body metabolizes the individual amino acids so rapidly and efficiently. Even if the food you're eating has a slightly differing amino acid composition profile, that gets altered once they consume that food because it changes in the bloodstream. So the effect of plant versus animal protein on insulin secretion, so far as we know, doesn't differ. And if it does, it's not by much. The same is true of liver fat. So when I was talking about protein being useful for reducing liver fat, again, there's probably not huge differences between animal and plant protein. So there it doesn't matter. But you're absolutely right. When it comes to insulin sensitivity, in my view, the plant-based diet wins over in every respect, in terms of whether it's the phytonutrients that we've now called them, whether it's the fiber, whether it's the reduction in saturated fat, because a high intake of saturated fat can impair insulin sensitivity. So if it's lower, that you're not going to get that happen. So all of the combined properties of plant-based protein undoubtedly improve insulin sensitivity compared to a animal protein-based diet. I would say, and I've designed menus for studies which are 30% of calories from protein from vegetarian sources, and it's very it's not impossible to achieve, but it takes planning. It is much easier by orders of magnitude to reach the amount of protein for those kind of diets with an animal based diet. What I tend to do in my practice is like most people in the UK still eat a lot of animal protein, but I always recommend supplementing it as much as possible with plant-based sources as well.
Awesome. When we're looking at animal proteins, does it seem to you that certain sources of animal protein are more beneficial or at least less deleterious than others?
I mean, it depends on what outcome. In terms of kind of cardiovascular outcomes, cheese is the most interesting one. I mean, whether it's the fermented products, but there's pretty good data on cheese that it compares very favorably even to butter. So cheese is an interesting one that I think stands out. Dairy products in general, I mean, they provide a bunch of nutrients most of the UK are deficient in. So potassium, calcium, magnesium, for example. The whey in dairy seems to be very insulinogenic. So to get that postprandial response, dairy seems like a pretty powerful driver of that. In general, the worse, and I use worse in quotes because it all obviously the dose is the poison. Things like butter and cream don't appear to have any benefits, but I think many people would agree that we've overstated the harms of these foods. Certainly the amount is the poison, and I wouldn't ever recommend getting a high saturated fat intake for people because so far as we know, there's no benefit of doing that consistently, whatever your health goal is. I can't think of a study where saturated fat replacing unsaturated fats came out on top. It's always that replacing saturated with unsaturated fat improves your outcome. So like I said, whether it's insulin sensitivity, liver fat, cardiovascular disease, etc., even ketosis. So if getting into ketosis is your goal, you're more likely to do that. There's limited evidence, but more likely to do that with high unsaturated. So that's my long way of saying that saturated fat doesn't have, so far as we know, health benefits, but we have overstated the harms of moderate amounts of it. So when I'm giving advice, I encourage in general dairy products, but things like butter and cream, I consider treats. Like if you like having scrambled eggs, use butter because it tastes nicer. Don't worry about avoiding it completely, but don't go crazy eating a lot. Like bulletproof coffee. Like there's no nutritional reason whatsoever to have bulletproof coffee.
I'm totally on board with that statement. Yeah, dairy's fascinating. Just the potential effects of the food matrix, right, and all of that emerging evidence on that. Yogurt seems to be particularly beneficial in this case. You mentioned the unique dairy proteins, whey and casein in particular, are beneficial. What about things like fish, for example? Does it seem like fatty fish might be beneficial in this respect?
I mean, do you mean in terms of management of type 2 diabetes?
Hmm.
Yeah, actually, I mean, so no. So, I mean, oily fish or any other kind of fish in the context of a healthy diet are good things to have because they're high in protein and they're going to protect you from cardiovascular disease. But the omega-3 fatty acids don't appear to do anything to glucose, not insulin secretion and not insulin sensitivity. The best evidence we have for fat type in terms of insulin sensitivity is the unsaturated fats. And basically replacing saturated with mono or the linoleic acid, it really is the predominant N6 fatty acid, improves insulin sensitivity. Even if you look at the phospholipid membrane of a skeletal muscle, the more polyunsaturated fat you have in that compared to saturated, the greater the insulin sensitivity of skeletal muscle. Now, to be clear, with the difference in fat classes on insulin sensitivity, the effect size is really small. So I would never suggest a modification of fat type as a method to prevent type 2 diabetes or manage it, because you'd need really huge differences in saturated to unsaturated fat intakes. So a huge difference in or ratio. And you would get a very small difference in improvement in insulin sensitivity. So it's not something that has much of a meaningful impact on insulin sensitivity, but the direction of the effect is towards poly and mono being more helpful.
Fantastic. I appreciate that insight. I think fat is a particularly confusing topic for people nowadays. You mentioned that, saturated fat might have been slightly overblown in the past, but we shouldn't get carried away with our saturated fat intake. We should probably limit it to some degree. A lot of people are becoming skeptical, or they say that PUFAs are downright harmful, right? And that seed oils are the devil, but it's not necessarily that simple. And I think the rationale that many people put forth to justify these claims is a bit suspicious at best.
Yeah, it's all based on rodent studies. So the whole seed oil thing, seriously, I mean, because every once in a while, like I'll read a statement by maybe someone I really respect, and it will be about seed oils, and I think, oh, is there a paper I've missed that actually does show harm of soybean or canola, whatever it might be? And I go and I look and I trace back which reference cited which reference, and you go back to like the start, and it's rodents, and rodents are hugely problematic for studying nutrition. For example, a high fat diet in rodent induces insulin resistance. It doesn't necessarily in humans. The whole seed oils being inflammatory thing. So this is the N6 leading on to certain pathways to produce inflammatory cytokines versus other types of fatty acids that reduce inflammation. Like that whole thing, it comes from rodents. And that hypothesis has been tested like 14 times in humans. I mean, the studies are of varying quality, but there's just zero evidence whatsoever to suggest that seed oils or linoleic acid, it causes a rise in inflammation in humans. It's not based on anything at all.
In that respect, I think it's almost ironic, right? Because a lot of people have their qualms with observational research, and that, clearly can't provide any insight into what's actually going on. But rodents, on the other hand, that's where the ticket is. We can accept those findings, and they're not just small humans. It doesn't necessarily transfer that way.
Yeah, and you know what, like you can tell someone's bias if a rodent study is a great study when it shows one of their favorite diets is beneficial. They think, oh, brilliant, high quality study done in rodent shows that low carb's great. And then if it shows something that is negative or that they don't like, they say, oh, it's just a rodent study. You can tell someone's bias. The same is true of epidemiological studies, where they'll complain, and quite rightly perhaps, about the limitations of observational research. And then I don't know if you remember Pure. This was an observational study that came out that had loads more flaws, in my opinion, compared to the Nurses' Health study or some of the other bigger cohorts. And then everyone who previously had slated the Harvard kind of epidemiology for being anti-low carb were then embracing Pure because it was pro-low carb. I mean, it's all very silly.
It's all about what's polarizing and hot takes. Nuance is an endangered species. No one is interested in it. We want simple stories. We want black and white answers. Leave the gray out of it.
Oh, exactly. And there's also this kind of goal that people seem to have to establish the one true best diet, and maybe it doesn't exist. And certainly when people, I get asked from magazines and a lot kind of like the lay press, what's the best diet? It depends entirely on what your outcome is. And even within that, there are multiple ways to get to the same goal. And that's one of the things that's also not helpful, that people kind of think, well, there's got to be one way. Which diet and which only diet should I be following and interested in? And which is, again, a bizarre way to approach the subject.
Yeah, it absolutely is. On the rodent topic in that research, I remember on the podcast we had on Dr. John Hawley, who recently released a paper. I believe in the title it was "From Mice to Men," and it was a paper on chrononutrition and time restricted feeding. And we went over the fact that these aren't just small humans. And as this literature continues to grow, it does seem that there might be something interesting going on when it comes to extending the duration of the daily fasting window. But when you look at the human research compared to the rodents, the contrast is significant. I mean, time restricted feeding is the end all be all in rodents. It doesn't matter like what they eat. If you just limit that feeding window, we see these robust benefits, whereas that's definitely not the case in humans. There's a little more control that needs to go into place to experience, any benefits at all from this approach.
Oh, I completely agree. Like, I think the most unjustifiably hyped diets are time restricted feeding. I think if you look at the entirety of the data, it's actually not exciting at all. And actually it can be a little bit worrying. And one of the things that I think is always worth bearing in mind is the financial model of journals nowadays. They want people to click on their journals, like everything on the internet. And I think what journals, like the BMJ publishes rubbish. I mean, the BMJ, it publishes nonsense in nutrition. And I hate to say it, so does Cell Metabolism. Cell Metabolism is this hugely prestigious journal. And it's hilarious that they would ever publish any dietary intervention without a control group when that intervention loses weight. Because no matter what you're measuring, if you're losing a lot of weight in a week or 2 weeks, your triglycerides are going to come down, so is your glucose, your insulin sensitivity is going to improve, your inflammatory markers are going to come down. You cannot ascribe that to your diet without controlling for weight loss. And Cell Metabolism publishes that. And so that's the point I'm coming to, is this time-restricted feeding study that was done in like 8 people. If I remember correctly, there wasn't a control group. And it was an early time-restricted feeding. And you know, actually, I mean, if there is a beneficial effect of time-restricted feeding, almost certainly it's early. So having to eat in the morning and not eat later on. And like, my view is, who would do that? What, no dinners, not going to the pub with your friends and having bar snacks, watching the sport, you know, not celebrating with fat, like how antisocial would that be? And the feasibility of that to me is, I've never had a patient in my life who has been able to follow early time restricted feeding long term, ever. I have patients on super low keto, so you're talking less than 20 grams of carbohydrate a day. They've sustained it for 3 years. I have patients on every kind of diet, and none of them have been able to follow early time restricted feeding. So I think it's a pretty poor and unexciting way of approaching metabolism or management of type 2 diabetes, certainly.
Yeah, I think if anything interesting is going on, it's definitely early time restricted feeding. And frankly, we have like the one magical trial on this from Sutton, showing that, you know, without changes in weight, we saw these improvements in systolic blood pressure, glycemic control, so on and so forth. But they stopped eating at 2 p.m. every day.
That's the one, right? Because they started eating the windows like 6 or 8 a.m. in the morning and stopping at 2, and it's like, well, who would do that? It you know, conceptually it's interesting to know that the impact of timing of food intake is so great, controlling for other factors, you know, conceptually, and in terms of understanding physiologically, that's interesting. But as a way of helping the population reduce their insulin insulin resistance, I see it as a non-starter. I mean, Camilla Peterson does awesome research on this, and I know she's comparing early to late. I don't think that data's out yet, but that will be interesting. But the best paper on intermittent fasting or time-restricted feeding is an American Heart Association consensus paper, and it goes through all of the studies. And if you read all of those studies, it doesn't look, for obesity, overweight, pre-diabetes, it doesn't look that exciting at all. In fact, if you have just one meal a day and a super duper long period of fasting, if the meal that you have is at night, that's actually worse for you than having 3 meals a day.
And when we look at that 3 meal per day compared to 1, that's part of that effect. So you mentioned eating late at night, and similar to the early time restricted feeding, it does seem like from a chrononutrition perspective or just circadian biology, when we look at how hormones are secreted and those profiles of the course of the day, it kind of makes sense that eating at night probably has a deleterious effect. But when we look at 3 compared to 1, the interesting thing is like the second meal phenomenon, right? And how basically how those meals can more or less like build off of each other to improve glycemic control in some respect. Do I have that right?
I mean, yes, I mean, the second meal effect occurs, to my knowledge, regardless of the number of meals you're eating a day. But I think the nighttime thing, like you just said, is, I think the reason for that, I mean, we've seen cardiometabolic effects, negative effects on blood pressure, I think triglycerides from having a lot of carb, in particular, especially having a lot of calories at night. But the point I guess I'm making is that that's what most people will do. If you say, okay, minimize the amount you're eating, most people I know can easily not eat in the morning. If you just say, well, don't have breakfast, they'll skip breakfast. In general, after a period of adaptation, I'm saying anecdotally here, most people are then able to not eat until 3 in the afternoon. So they can not eat anything in the morning, and they might eat at 3 in the afternoon, and then they'll eat maybe one meal at 3-4 p.m. and another at 9 p.m. So that's what people will do if you tell them that eating just 1 or 2 meals a day is beneficial for metabolism. Literally no one is going to eat a meal at 7 a.m. and 1:30 p.m. and then not eat anything for the rest of the day, in my opinion.
Yeah, anecdotally, when I have clients come to me and they're like, "Oh, I follow time restricted feeding," or they're probably just going to refer to it as intermittent fasting, and I'm like, "Look, that's an umbrella term. Like we have all of these things that fall underneath it. Like usually the earliest meal in their day is 12 p.m. and I'm seeing consumption from 12 p.m. to 8, or maybe they're starting at 1 or 2. It's never like it's never anything even close to early time restricted feeding.
Yeah, and I think, I don't know if you saw Ethan Weiss's study that was published, was it last year in Internal Medicine? And there is, I know that study wasn't super controlled, but I think there is some worrying data there on lean body mass. And maybe it's simply because you don't get enough protein, or it's the frequency of protein intake there. But that's not something you'd want to occur long term as well. So yeah, I'm pretty skeptical about time restricted feeding. And in general, the only time I really use it with my patients is if it's, as an approach, the only way they can maintain weight loss. So let's say they've achieved weight loss and they're really struggling to maintain it. If by consuming 2 meals a day, it helps them maintain weight loss, I consider that a pragmatic approach, because the effect of weight loss maintenance itself, you would imagine, would outweigh any smaller metabolic impact of circadian rhythms.
Yeah, I think the magic of time restricted feeding is that, we've seen that you can simply tell people to limit their daily feeding window and provide no other nutrition education whatsoever. And by default, they'll decrease their calorie intake and lose weight. And in that respect, it's magical. But other things that people like to put forth, fun words like autophagy, that's what's driving these
Oh
benefits,
yeah,
and
yeah,
so on and so
yeah.
forth. I don't think that's the ticket.
Yeah, absolutely. And there's this bro science. I'm sorry, I might offend lots of your listeners by using that term. There's this bro science field where it rejects nutrition because it seems vague, and it is. Nutrition science is vague. There are so many unknowns, and they replace it with this model that just massively extrapolates from in vitro models or rodent models of what's happening. And it's a very reductive way of looking at things, because like you say, they'll focus on mTOR, for example. That sounds really sciencey and super intelligent and convincing maybe to some people, but you've got to consider all of the signaling pathways as a whole. And that's what we think we're doing when we collect outcomes, whether it's tissue insulin sensitivity, whether it's muscle, those kind of things. Like I don't buy that reductive look at this one transcription factor or this one hormone approach to managing diet.
Yeah, I'm not really familiar too much with the longevity research, but from my understanding, a lot of people like to put forth that specific amino acids or overstimulating mTOR probably has some long-term repercussions. Then we see these quote unquote longevity diets that have like really low protein intake. But if we look at other perspectives on this and severely limiting protein intake and the potential consequences for sarcopenia down the road and just how prevalent that is, it's like, well, say the former is completely true in all respects. We would, and it might not be, but we still need to weigh that out with the consequences of severely restricting protein on muscle mass down the road and just metabolic function as a consequence of that.
Oh, completely. Yeah. Like if you took, the biggest effect on longevity is going to be things like obesity, type 2 diabetes, etc. If by consuming a high protein diet you can lose 10 kilograms, lower your glucose, blood pressure, everything else, that's going to have a far greater impact on your longevity than the potential negative impacts of excessive protein via mTOR. And this goes back to kind of what we were talking about with the one true diet. It depends on who you are. Maybe for some slim athletic person, reducing or maybe not reducing, but not getting excessive protein intake, wherever that cutoff is, maybe that's a good idea for longevity. But I think if you look at the empirical data we have, everyone over the age of 60 benefits from more protein, because the way we metabolize protein changes after the age of 30, and it gets worse with every decade. So certainly with that age group, I think and even this is even reflected now in clinical guidelines, that they need more protein. You then have the type 2 and the cardiometabolic group. And, this is early days at the moment, but I think we'll see more and more evidence showing high protein is beneficial for those clinical conditions. And so it becomes a more nuanced question, the whole longevity thing. And I would also add, like, to just add some nuance, studies that your listeners might not be aware of. High protein intake compared to low protein intake in infancy, so the first year of life, causes greater adiposity in childhood. So in other words, if you get too much protein when you're transitioning, say, to formula, or in the first year of life, maybe first 1,000 days of life, that causes greater adiposity for reasons we don't really understand. So people think it might be IGF-1, but studies don't suggest it is. And so all of this put together kind of tells you the right diet depends on the stage of life, the person's clinical or metabolic background, their particular goals. And in general, I think the evidence is stronger for protein than against for most people that we will interact with.
I love that context. I think the listeners might have an idea of how you'll respond to my next question, but as we wrap up these thoughts on time restricted feeding, it seems like within the community that prescribes to a ketogenic diet, it's usually used in combination with some sort of intermittent fasting approach or restricting the feeding window, and together these strategies are just quote unquote optimal for managing type 2 diabetes. I guess give us your take specifically in regard to that, and whether anything uniquely beneficial could be going on with this approach.
Regarding keto and intermittent fasting?
Yeah, putting those together to manage type 2 diabetes.
Yeah, I mean, so I think ketones are really interesting. John Little is an amazing researcher up in Canada, and he's published very recently work looking at ketones or exogenous ketones, which is a useful way of looking at it because you can isolate the effect of the ketones on metabolism. And what he's shown acutely, and he published in December of last year, over maybe it's 2 weeks, maybe it's 12 weeks, but it's a kind of continuous study that improves glucose tolerance. And that's interesting because that's controlling for other factors. We also have studies that compare very low energy diets that are ketogenic and not. And the ketogenic one seems to reduce hepatic glucose output. So I think ketones themselves are very difficult. So I do see a role for people who like it of a ketogenic style diet that does produce a lot of ketones. I think there's probably something in that. But you've got to be super low carb. I, for the record, don't think that controlled for protein, simply reducing carbohydrate to 80 grams a day necessarily does anything. I think the adaptations we talked about earlier would just cause your blood glucose to stay the same. So I think to be beneficial, it's got to be keto. And the other thing that could also be beneficial of that is that if you're massively reducing your carbohydrate intake, you're reducing hepatic glucose output, you can probably normalize blood glucose levels. And again, as we talked about, that, if you do it for long enough, could normalize your pancreatic function. And I'll just say there's data from Virta. So Virta are a company that have a kind of ketogenic type 2 diabetes program. And it's hard to interpret because there are a few confounding factors, but there's a chart showing insulin use at baseline at 1 year and 2 years. And typically what you would expect from any study ever done is that people lose weight at 1 year. Of course, you expect medications to come down. At that time, people nearly always plateau or they start to regain weight. And if they do that, what you would expect to see is an increase in the requirement for diabetes medications. But with Virta, you don't see that. In fact, you see a further reduction in insulin dose. And I wonder whether that's because of what we were talking about, that you have ketones that improve hepatic glucose output, blood glucose, and all of that stuff. And all of this together over a long period of time can help people come off insulin and stay off insulin. That needs to be tested properly, but there are models we could do that in. But I could buy a ketogenic diet as being very beneficial for type 2 diabetes.
Very interesting. Dr. Guess, I have one more question for you. This is a question that I've been ending episodes with prolific nutrition researchers and practitioners to get their thoughts on. It could be an entire episode in itself. So whatever the first thing that comes to mind is, shoot. But when we look at these rising rates of obesity and cardiometabolic disease, where have we gone wrong in our quest to attenuate this crisis? Should we be shifting our research focus elsewhere? What are your thoughts? How do we stop these rising rates?
I mean, I think it's all to do with the built environment, or a huge part of it is. And people criticize the dietary guidelines and say, oh, that's what's caused people to eat incorrectly. And my response to that is, well, what are the physical activity guidelines and how many people actually follow them? And I lived in Houston for a year, and I've actually come back from living in Kuwait for a year. Both are cities where you can't move around much. And in Kuwait, I think my diet was the same. I gained 7 kilograms because the environment I was living in did not permit me to do the same amount of free living activity I do in London. So your environment is such a huge driver of the physical activity you take and what you eat. And if you consider, most of us are advertised to every 5 minutes of every day, whether you're leaving the movies, whether you're driving home, you're at the gas station, whatever it might be, you will be exposed to food. All of it will be really palatable, heavily marketed, designed in such a way to make us crave it. And my reason, or my thinking about the obesity crisis, is human beings really like food. If we didn't, we'd have died out long ago. And unfortunately, we live in an environment that puts that, on steroids, our craving for food and our ability to eat it. And I don't think it's any more complicated than that, really, for the vast majority of obesity in society.
Fantastic. I think we're coming to a consensus of sorts on the podcast. There's no reason for bags of Skittles to be at the checkout when you're buying a new sweater.
Right. Oh, exactly. Yeah. Or everything being supersized. Yeah. I worked at Imperial for 5 years, and they had a professor who was head of the Department of Medicine, who was an incredible obesity researcher and a very wise man. And he said, you should think about obesity like this. It's not surprising anyone's overweight at all. It's amazing anyone's thin. And I think that's the lesson that we all need to take. Actually, lean people are the minority now in most populations. And I think that tells you about what the major driver of obesity is. It's our environment.
Absolutely. Dr. Guess, I really appreciate your time today. This has been a fantastic discussion. For our listeners who want to learn more about you, go and support you, where can we lead them towards?
Oh, I'm on Twitter and Instagram. Twitter is my more kind of wonky nutrition wonk platform where I talk about science and data and stuff. It's Dr__Guess, so 2 underscores. And I'm on Instagram, which is more patient focused.
Excellent. Those links will be in the show notes. Do we have any upcoming projects to look forward to? Any publications in the works?
Yeah, so I have, and we're publishing it right now, or trying to get it published, is looking at different doses of carbohydrate on glycemia in type 2 diabetes within a range that we call low carb, and that's controlled for the major confounding factors. So we're having that reviewed at the moment. I'm running 2 separate studies looking at altering the amount of protein in the diet against a background of carbohydrate restriction, and those are attempting to really nail down on whether it's protein that's doing this in a more controlled fashion. One is entirely animal protein based, one is plant-based protein. And then we're also doing work on NAFLD in type 2 diabetes as well.
Fantastic. I am looking forward to seeing those when those get published. Everyone,
Great.
that does it for another episode of the Muscle Memoirs Podcast. Thank you so much for listening. Hey guys, Mike here. If you're interested in learning more about how to maximize your health, body composition, and performance, head over to hammerawayfitness.com, where you can sign up for coaching or even just schedule an hour consult with me to get some of your training and nutrition questions answered. Also, if you enjoyed this episode as much as I did and would like to further support the growth of the Muscle Memoirs podcast, you can give a donation to the link in the show notes, leave us a review, and or share this episode with your friends, whether that be dropping the link in a group chat or putting a screenshot in your Instagram story. I truly appreciate it.